Hi friends, this is Pavati from OPRA-KAPS. Welcome to my channel. I need your support, so please subscribe, share and like my videos. Also, you can mention your valuable comments in the comment box. Today we are discussing here the adrenergic agonists. This is the pharmacology video number 3. And the previous videos you can check it for the remaining portions, whatever we done before, okay? And one more thing, at the end of this adrenergic agonist chapter, some of slides I mentioned the question discussion from the Lipin code. I am following the 6th edition of Lipin code. You can check it if you want. You can check it the same one. The questions I forgot to included in the previous slides for the previous chapters, so that's why I mentioned in here, okay? If you want, you can check it that one. It's very helpful. And if the slide is not clear, you can check in the description box. I mentioned the link on there. You can check it that one also, okay? Don't forget to check it. It's very helpful, okay? We can remind it to everything. And we can start from the adrenergic agonist. So the first slide I mentioned, as usual, the sympathetic and parasympathetic actions, because we want to understand this one thoroughly. Then only we can continue the remaining chapters. So that's why again I mentioned in the first slide this one, okay? So adrenergic agonists that mimic the effect of sympathetic nerve system. So that's why it's called the sympathomimetic, same as like sympathetic action, okay? These drugs mainly activate the adrenergic receptors, or otherwise we can call adrenoceptors, okay? What are the main actions of adrenergic agonists? They are leading to the response such as increased heart rate, dilation of pupils, that means mydriasis, and relaxation of airway muscles, similar to the body's natural, same as like fight or flight response. So that's why it's called fight or flight response, okay? And the neurotransmitters mainly in the adrenergic agonists, norepinephrine and epinephrine. Norepinephrine we can also known as noradrenaline. Epinephrine also known as adrenaline, okay? And I already mentioned this point before, previous slides also. Adrenergic drugs means it's activate the adrenergic receptors. So that's why it's called sympathomimetics. Some of the adrenergic drugs that block the activation of adrenergic receptors, these are called also known as sympatholytics, okay? In the next slide, I mentioned some of the sympathomimetics are directly activate the adrenergic receptors. These are called direct acting adrenergic agonists. Some of them are indirectly by enhancing the release or blocking the reuptake of norepinephrine. These drugs are called indirect acting agonists, okay? One of the important points we want to understand it, okay? So that's why I highlighted. And the next portion we are discussing here, the synthesis of norepinephrine. Everybody know this one, and this picture also very familiar. Whenever we are studying in the B Pharm also, it was one of the important topic, okay? Just recollect everything. And I mentioned the description here. First, the tyrosine, it's converted to dopa by hydroxylation. Enzyme is activating here. The tyrosine hydroxylase is convert this tyrosine to dopa. That means it's transported to the adrenergic neuron. Then the dopa is converted to dopamine by decarboxylation. The activating enzyme is aromatic L-amino acid decarboxylase, okay? This dopamine is formed in the presynaptic neuron. And then the dopamine is converted to norepinephrine by hydroxylation again. Enzyme here, dopamine beta hydroxylase. And it's transported to, that means the dopamine is converted to norepinephrine. It's transported to the synaptic vesicles. This carrier system we can block by reserpine. One of the important point, we can expect a question based on this one. So that's why I highlighted that point also. Reserpine is block the conversion of dopamine to norepinephrine in the synaptic vesicles, okay? To the synaptic vesicles. Then the norepinephrine is, it's formed in the synaptic vesicles. We want to release the norepinephrine from there. So, what is happening on there? The action potential is arriving in the synaptic vesicles. Then the calcium influx is causes. That means calcium is increasing. Then the fusion of vesicles with the cell membrane. This process is called exocytosis. Then the content is expelled from the vesicles to the synapse, okay? It's release the norepinephrine from the synaptic vesicles to the synaptic space. This is happening on there, and this system we can block by the guanethidine and beryllium. One of the other important point, we can expect the question based on the guanethidine, beryllium and reserpine. Okay. Then the release of norepinephrine, it's bind to the presynaptic receptors on the effector organ or to presynaptic receptors on the nerve ending. This is happening on that. Then the removal of norepinephrine, then it's norepinephrine reuptake back into the presynaptic neuron, we already discussed. This one, it's metabolized by the COMT or MAVO, okay. It's oxidized by the COMT or MAVO. And this system, this transport is, that means the metabolism is, conversion of this one can inhibited or blocked by the cocaine and imipramine. That means the reuptake is inhibited by SNRIs. So the reuptake is inhibited by SNRIs, that is serotonin reuptake inhibitors, mainly cocaine and imipramine. So these highlighted points are very important, mainly reserpine, beryllium, guanethidine, cocaine and imipramine. We can expect questions based on this. Okay. From the next slide, we are discussing the adrenergic receptors or the adrenoceptors. Mainly two types of receptors, alpha and beta. So what are the important receptors in the adrenergic receptors are coming? Alpha 1, alpha 2, beta 1, beta 2 and beta 3. So the rank order of potency of alpha receptors is mentioned here. Epinephrine is the first position or equal to the norepinephrine. Okay. Then the third position is coming for the isoproterenol. Rank order of the beta receptors potency for rank order this one. Isoproterenol in the first position, then epinephrine, then norepinephrine. Okay. And the next slide, I mentioned the summary of the adrenoceptors actions, description in the coming slides. So we can just thoroughly with from this picture also, okay. In the first one, alpha 1 receptors. Alpha 1 receptors main actions are vasoconstriction, increased peripheral resistance, increased BP, mydriasis, that means dilation of the pupil, and increased cluster of internal sphincter of the bladder, that means urinary retention. Main locations of the alpha 1 receptors are postsynaptic membrane of the effector organs, mainly blood vessels, iris, prostate, urethral sphincter, pylorus and anal sphincter. From the actions we can predict the locations of this one also, okay. And then the next one is alpha 2 receptors. Alpha 2 receptors, the main actions are inhibition of norepinephrine release, inhibition of acetylcholine release, inhibition of insulin release. If the insulin is inhibition means hyperglycemia is producing on that. That means the glucose level is increasing. One of the important point, okay. Please thorough with these points. Very, very important. These actions, very important. Okay. And the location of alpha 2 receptors is presynaptic nerve terminal, mainly the pancreatic beta cell, platelets and vascular smooth muscle. Okay. Next one is beta 1 receptors. Beta 1 receptors, we know it's mainly the heart. The location is heart, kidney and adipose tissue. So the heart is location means whatever happening on there. For the beta 1 receptors, tachycardia, increased lipolysis. Tachycardia means increased heart, right? It's also we can call this one chronotropic effect, okay? Then the second one is increased lipolysis, increased myocardial contractility. That means the force of contraction is increasing. We can also known as inotropic effect, okay? Then the last one is increased renin release, okay? Then the next one is beta 2 receptors. Vasodilation, decreased peripheral resistance, bronchodilation, increased muscle and liver glycogenolysis, increased release of glucagon, that means glucose level is increased, so hyperglycemia is the side effect. For this thorough with this one, okay. So that's why I mentioned here. Maybe we can expect the questions based on that. And the last action is relaxed uterine smooth muscle. It helps to relax the smooth muscles, mainly the beta 2 receptors action. So one of the important points is terbutaline is used in preventing the premature labor. One of the important point based on this one, okay. And the locations of the beta 2 receptors are lungs, blood vessels, uterus, liver and skeletal muscle. Okay. The last one and the final one is beta 3 receptors. Beta 3 receptors play a crucial role in lipolysis and thermogenesis, and specifically in the detrusor muscle, helping to relax the bladder muscles. Okay. The location of beta three receptors is adipose tissue and urinary bladder. From the location we can predict the actions of this one also. Okay. And from the next section we are discussing some of the important points based on the receptor action. It's very important. We can expect the questions based on this in the CAPS or OPERA, because it's very important actions are the beta receptor. Okay. The first action is beta 1 receptor agonist. It's showing the arrhythmic effect. The main reason is beta 1 action is coming on the heart, so it's increased the heart rate. Increased heart rate means tachycardia, we can call tachycardia. Okay, so it's producing the arrhythmic effect. Arrhythmia, we know its variation of the heart rate is called the arrhythmia. Okay, the beta 1 receptor antagonist means it's blocking the action of beta 1 receptors, so that means it's producing the anti-arrhythmic effect. Anti-arrhythmic effect means it's decreasing the heart rate, so that means it's bradycardia. Okay, and beta 1 adrenoreceptors are activated. What's happening on there? It increases the slope of the pacemaker potential, and it's leading to positive chronotropic effect. We know positive chronotropic effect already we discussed previous slide. It's increased the heart rate, and also it's showing the positive inotropic effect. Inotropic effect means increased force of contraction. Very important. Please thorough with these points. Okay. And next point is beta 2 antagonist and non-selective beta blockers are contraindicated in asthma. The main reason we know the beta 2 receptors action is bronchodilation. So beta 2 antagonist means it's blocking the action of beta 2 receptors. So it's worsen the condition of asthma. So that's why it's contraindicated in asthma. The same effect is non-selective beta blockers also. Okay, but the next point we are discussing here, selective beta blockers are safe in asthma. That means selective beta blockers also it's known as cardioselective beta blockers. We know the beta 1 receptors action is mainly in the heart, least effect only in the lungs. So that's why the selective beta blockers are safe in asthma. Okay. Very important. We can expect the questions based on this also. Okay. The next point is tamsulosin is used to treat urinary issues in patients with BPH. BPH means benign prostate hyperplasia. What's happening on there? BPH patients have urinary retention, so that's why we are using the tamsulosin in this case. Tamsulosin helps to increase the urination. Okay, these are the important points based on the receptors action. Please thorough with this one. It's very important. Okay, the next section we are discussing here, characteristics of adrenergic agonist. Not that much important, for the introduction purpose I mentioned here. So adrenergic agonists, it's derivatives of the beta phenylethylamine, and it's also coming catecholamines, non-catecholamines. The catecholamines mainly epinephrine, norepinephrine, isoproterenol and dopamine. Non-catecholamines coming this one, the main drugs are phenylephrine, ephedrine and amphetamine. And the dobutamine also adrenergic agonist, but it's a synthetic catecholamine. Okay. The next slide I mentioned here, the common adverse effects of adrenergic agonists. These are mainly arrhythmia, headache, hyperactivity, insomnia, nausea and tremors. Important adverse effects are very important. Please thorough with these points also. Okay. And the next section I mentioned here, the drug classification of adrenergic agonist. Mainly three types are coming: direct acting, indirect acting and mixed action. Direct acting, the drugs are mainly epinephrine, norepinephrine, isoproterenol, dopamine, phenoldopam, dobutamine, oxymetazoline, phenylephrine, clonidine, albuterol and terbutalin, salmeterol and formoterol, mirabegron. Okay. The next classification is indirect acting. Three drugs are mainly discussing here: amphetamine, tyramine, cocaine. Mixed action, that means direct and indirect acting. Two drugs are discussing here: ephedrine and pseudoephedrine. These are the classifications of adrenergic agonists as per the Lippincott 6th edition. Okay. And the next section we are discussing the drugs separately. First one is direct acting adrenergic agonist. That means it's also known as sympathomimetic. That we know sympathomimetic means same as like it's increase the and it mimics the stimulation of sympathetic nerves or the release of norepinephrine from the adrenal medulla. These are mainly directly acting on alpha and beta receptors. Main drugs we are discussing here: epinephrine or adrenaline, norepinephrine or noradrenaline, isoproterenol, and phenylephrine. The first drug is epinephrine, very important drug. So many questions I highlight, so many points I highlighted here. These are very important. Please thorough with these points also. Okay. The epinephrine main overall action is coming increasing BP, blood pressure. Okay. And epinephrine, it interacts with both alpha and beta receptors. So the epinephrine in the lower dose, it's showing the beta effects. Beta effects, we know it's vasodilation on the vascular system. Okay. And in the high dose, it's showing the alpha effects. Alpha effects, we know it's vasoconstriction are the strongest. It's showing the epinephrine. Okay. And the receptor specificity is mainly alpha 1, alpha 2, beta 1, beta 2, and beta 3. So next point, we are discussing the actions in each actions of the epinephrine. The first one is cardiovascular. The major action of epinephrine are on the cardiovascular system. The first one is increased myocardial contractility, that is positive inotropic effect, and it's beta 1 action mainly. And also it increased the heart rate, that is we are calling like positive chronotropic effect, that means tachycardia. It's also beta 1 action. We know the beta 1 is mainly on the heart. Okay, so that's why these actions are coming here. So both these action, because of these actions, the cardiac output is increased, so it increased the oxygen demands on the myocardium also. The next section we are discussing here, actions of epinephrine in kidney. Mainly it activates the beta 1 receptors. What's happening on there? It's increased the release of renin. Renin release is happening there, and the renin means it's an enzyme. It's involved in the production of angiotensin 2. So that's why it's called a potent vasoconstrictor. Okay. The next point is epinephrine. It's constrict the arterioles and the skin mucous membrane. We know the epinephrine, we already discussed the receptor specificity. It's also showing the alpha effects. Because of that, it's constrict the arterioles in the skin and mucous membrane. The next point is dilate the vessels going to the liver and skeletal muscle. That means we already discussed epinephrine have beta effect also. So the beta 2, because of the beta 2 effects, it's dilate the vessels going to the liver and skeletal muscle. The next point is renal blood flow is decreased. The reason is renal blood flow is decreased. What's happening there? It's increased the systolic BP and slight decrease in the diastolic BP due to the beta 2 action. That means the vasodilation is happening on there. Okay. The next one is respiratory actions of epinephrine. Epinephrine action on the respiratory. What's happening on there? It's producing the bronchodilation. We know the beta 2 effects by acting directly on bronchial smooth muscle. And it inhibits the release of allergy mediators such as histamines from mast cells. It's decrease the release of allergy mediators also. The next one is it's producing the hyperglycemia. Hyperglycemia, what's happening? Mainly it's a beta 2 action. Significant hyperglycemic effect because it's increased the glycogenolysis in the liver. So that's why the glucose level is increased on there. Okay. That is this is a beta 2 effects it's showing. And also it's increased the release of glucagon and decrease the release of insulin. Increase the release of glucagon, that is beta 2 effects, and decrease the release of insulin is alpha 2 effects. If you thorough with the receptors action, these points we can understand very easily. Okay. The next one is lipolysis. Lipolysis means it initiates the lipolysis through agonist activity on the beta receptors of adipose tissue. We know the beta receptors, mainly the beta 3 receptors on the adipose tissue. So the lipolysis is initiates through this agonist activity. And the next section we are discussing here the uses of epinephrine. The first use is it's used in the bronchospasm. We know the epinephrine have beta 2 action, so it's used in the treatment of acute asthma. It's producing the bronchodilation, so that's why it's using. So mainly the drug is example mentioned here, albuterol, and it's also used in the anaphylactic shock. Anaphylactic shock means it's a severe type of allergic reaction is called anaphylactic shock. So the drug of choice for treatment of type 1 hypersensitivity reactions, we can use the epinephrine. And next use is cardiac arrest. We can use the epinephrine in cardiac arrest because it's restored the cardiac rhythm. So that's why it's used in this case, okay. The next use is increase the duration of action of local anesthetics by producing the vasoconstriction at the site of action. We already discussed the epinephrine have alpha effects. It's producing the vasoconstriction. So that's why it's increased the duration of action of local anesthetics by producing the vasoconstriction at the site of injection. The next point, we are discussing the pharmacokinetics of epinephrine. Mainly the route of administration for epinephrine is IM, IV and subcutaneous. Then it's the other point we are discussing, the rapidly it's metabolized by MAVO and COMT. Also the metabolites are the metabolites is producing by the epinephrine by MAVO and COMT is metaepinephrine and vinyl mantelic acid, okay, or it's excreted through urine, okay. The next point we are discussing here, the adverse effects of epinephrine. Mainly it's showing the CNS effects that include anxiety, fear, tension, headache and tremor, and also it's triggered the cardiac arrhythmias. These points we already discussed because of the beta 1 action and non-selective beta 1 and beta 2. It's triggered the cardiac arrhythmias, okay, and it's induced the pulmonary edema. The next point is very important. Patient with hyperthyroidism, if they are using the epinephrine, we want to adjust the dose for this patients, because the patients with the hypothyroidism, what's happened there, it's increased the cardiovascular function also. So that's why we want to adjust the dose of epinephrine for this patient. We want to reduce the dose of epinephrine, and it also increases the glucose level. So in diabetic patients, we want to increase the insulin dose. If the patient is using the epinephrine, we want to increase the insulin dose also. We can expect questions based on these highlighted points, whatever I mentioned here. Please understand and thorough with these points also. And non-selective beta blockers prevent vasodilatory effects on epinephrine on beta 2 receptors. That means it increased the BP also. These are the main adverse effects. The next drug we are discussing here, the norepinephrine. Norepinephrine mainly it's given by IV because the reason is it's producing the rapid onset of action. And the receptor specificity mainly alpha 1, alpha 2 and beta 1. And alpha receptor is most affected compared with the epinephrine, okay. And the first action is coming for the cardiovascular action. It's producing the vasoconstriction. We know it's showing the alpha 1 effect, so that's why it's producing the vasoconstriction. That means it increased the peripheral resistance, so that's why it's increased both systolic and diastolic BP also. The main point is norepinephrine causes greater vasoconstriction than epinephrine because it does not induce the compensatory vasodilation via beta 2 receptors. It's least effect on beta 2, so that's why it's producing greater vasoconstriction compared with epinephrine, okay. And it's also not used in the treatment of asthma or anaphylaxis. We know the reason is it's not producing the beta 2 action, least effect on beta 2, so that's why. The next point we are discussing here, baroreceptor reflex. That it's producing the norepinephrine is increases the BP. It's by stimulate the baroreceptors and it's increase the vagal activity and it's produce the reflex bradycardia also. Okay, one of the important point, we can expect questions based on this also. So that's why I highlighted these points here, okay. The next section we are discussing here the therapeutic uses of the epinephrine. Mainly it's used for the treatment of shock. Shock, the condition mainly it's a life-threatening condition. It's resulting extremely low blood pressure following an infection also. This condition is called shock. So the treatment of shock we can use the norepinephrine. The main adverse effects are it's same as similar to epinephrine. In addition, the norepinephrine we already mentioned it's a potent vasoconstrictor and it can reduce the blood flow to the tissues if administered improperly. That means it's leading to tissue necrosis. What's happening if the extravasation is happening on there, maybe it's affecting the site of injection, so it's producing the tissue necrosis. So that's why we want to careful monitoring during use. Okay. And impaired circulation from the norepinephrine we can treat it with alpha receptor antagonist phentolamine. We can use this one phentolamine for the norepinephrine circulation have any problem, we can use the antagonist phentolamine. Okay. And the next drug we are discussing here, the isoproterenol. Isoproterenol, the receptor specificity mainly beta 1 and beta 2. The intense stimulation of that means we know the beta 1 action is mainly on the heart, so it's producing the increasing heart rate and increasing the contractility and cardiac output also. These are mainly the beta 1 effect. Beta 2 we know it's producing the vasodilation, that means it's dilate the arterioles of the skeletal muscle. The main uses for the isoproterenol is cardiac stimulant because of the beta 1 effect. Okay, beta 1 receptors action. The next drug we are discussing here, the dopamine. Dopamine, the receptor specificity we know alpha 1, beta 1, and also it's producing the effect on the specificity receptor on dopaminergic D1 and D2. In the higher dose, at the higher dose, what it causes vasoconstriction effect because of the alpha 1, and lower dose it's producing the beta 1 cardiac receptors. So also, okay. In the first action we are discussing here the cardiovascular actions of dopamine. Dopamine have both positive inotropic and positive chronotropic effects. We know it's the dopamine have actions on beta 1, so that's why it's increased the heart rate, that is chronotropic, and it's also increased the force of contraction, that is inotropic. Okay, and it's also producing the at high doses the dopamine activates alpha 1 receptors and it's producing the vasoconstriction effect also. In the renal and visceral, the dopamine dilates the renal and sphinctic arterioles by activating the D1 and D2 receptors, and it's increasing the blood flow to the kidneys and otherwise versa also. Okay, not that much important points, but please understand with the receptors action we can easily identify the question answer in the exam also. Okay. The main therapeutic uses of dopamine is it's used for the treatment of cardiogenic shock and septic shock. The main actions of D1 and D2, because of that we are using this one. And it's used for the treatment of congestive heart failure. We know these drugs have also action in beta 1. Because of that, heart is enabled to pump the blood effectively to meet the body's needs. That condition is called congestive heart failure. And it's also used in the hypotension. That means we can increase the blood pressure. So that's why the dopamine is used in hypotension. Okay, these are the main uses of dopamine. And the next drug we are discussing here, the phenoldiazepam. Phenoldiazepam, it is an agonist of peripheral dopamine D1 receptors, mainly the receptor specificity coming for the phenoldiazepam. It's a rapid-acting vasodilator. It's used to treat the severe hypertension. In hospitalized patients, the severe hypertension case, we can use these drugs. Okay. The main ADR for the phenoldiazepam are headache, flushing, dizziness, nausea, vomiting, and tachycardia. Okay. the one of the important point for the phenoldiazepam, it's producing the reflex tachycardia due to the vasodilatory effects. So it's producing the reflex tachycardia occurs as a compensatory mechanism. When the blood pressure drops, it's leading to an increase in heart rate. So that's why to manage the alpha 1 blockers can be used. That means this condition we can manage by using alpha 1 blockers. That means we can decrease the heart rate. So that's why alpha 1 blockers is used for this case. And the vasodilated drugs can cause reflex tachycardia also. It's a side effect for this drug. Example, the same as like another drugs are nitrates, that main drug is nitroglycerin, and calcium channel blockers, nifedipine and amlodipine. These are another example, same as like this drugs. That means the phenoldiazepam is producing the reflex tachycardia. Also the other drugs whatever we are discussing here, nitroglycerin, nifedipine and amlodipine, these drugs are mainly vasodilated drugs. So it's the point is mainly explained the vasodilated drugs also, the vasodilated drugs, they can produce the reflex tachycardia. These category drugs, the phenoldiazepam, nitroglycerin, calcium channel blockers, these are mainly vasodilated drugs. Okay. The next drug is we are discussing here dobutamine. Dobutamine, the receptor specificity mainly beta 1. So we can expect mainly the action on heart. Beta 1 is mainly heart. So and the dobutamine we already discussed this one. It's a synthetic catecholamine and its use is mainly in the treatment of acute heart failure. During increases the cardiac output and does not significantly elevate the oxygen demands of myocardium. Not that much important point, but just understand these things, okay? And the dobutamine should be used with caution in atrial fibrillation because it increases the AV conduction. So that's why we want to care with if the patients have any atrial fibrillation effect, we want to caution the using of dobutamine also. Okay, atrial fibrillation means it's an abnormal heart rhythm. That means arrhythmia. We know the variation of the heart rate. The condition is called arrhythmia. It's characterized by rapid and irregular beating of the atrial chambers of the heart. This condition is called atrial fibrillation. So if the patient have the atrial fibrillation, we want to caution the using of dobutamine also. Okay. And the next point we are discussing here, if the patient have arrhythmia, that means tachycardia, variation in the heart rate, increasing the heart rate, should be careful if giving the dobutamine because the dobutamine have beta 1 agonist effect. We know the dobutamine is mainly showing the affecting beta 1 receptors. That means it's showing the positive inotropic and positive chronotropic effect. That means increase the force of contraction and increase the heart rate. And it also increases the AV conduction also. So that's why one of the important point for the dobutamine, we can expect questions based on this also. Okay. And the next drug we are discussing here, oxymetazoline. Everybody is familiar with this drug. We know mainly the nasal spray we are dispensing this one. Okay, the main receptor specificity is coming alpha 1. Alpha 1 we know vasoconstriction. So its main use is coming for the nasal decongestant. It's used as a nasal decongestant. Oxymetazoline directly stimulate the alpha receptors on blood vessels, supplying the nasal mucosa and conjunctiva, thereby producing the vasoconstriction. That is the main action of alpha 1, and it's decreasing the congestion. That is the action of oxymetazoline on blood vessels. Okay, blood vessels supply to the nasal. Okay. The main side effects are mainly nervousness, headache, trouble in sleeping, and also it's producing the rebound congestion. We know the oxymetazoline mainly we are dispensing for 3 days. If the patient is continuing after 3 days, the main adverse effect, the main side effect for this one, rebound congestion, very very important point. We can expect the questions based on the duration of action and the side effect of the oxymetazoline. Okay, the important point I mentioned here, patients taking alpha-1 agonist drugs should use the oxymetazoline with caution because due to the potential for increased blood pressure. So that's why we want to caution with the, if the patient is using the alpha-1 agonist drugs, if patient is using oxymetazoline, the condition will become worsened. Okay. The next drug we are discussing here, phenylephrine. Phenylephrine, the receptor specificity mainly alpha-1. It's a vasoconstrictor also, and it raises the systolic and diastolic BP, and it's no effect on the heart, but induces reflex bradycardia when given parenterally. Okay. So if it's given by parenterally, it's producing the reflex bradycardia by phenylephrine. The main uses for the phenylephrine is, it's used as a nasal decongestant because we know it's producing the alpha-1 specificity, so that's why it's used as a nasal decongestant, and it's also raise the blood pressure. And the raise the blood pressure, the reason is it's used, so that's why it's used for hypotension patients. If the patient is hospitalized or the surgical patients, we can use the phenylephrine to raise the BP. Okay, and it's also used in the ophthalmic solution for mydriasis. We know mainly dilate the pupils, for that purpose we can use this phenylephrine also. And it's also used in the treatment of paroxysmal supraventricular tachycardia. What is the paroxysmal supraventricular tachycardia? I mentioned the definition here, not that much important, but for understanding, that's why I mentioned the definition here. Okay, just read it. Okay. The next drug we are discussing here, the clonidine, one of the important drugs, same as like epinephrine. This drug also very very important. Okay, clonidine, the receptor specificity mainly alpha-2. So it inhibition of, we know the main alpha-2 receptors action is inhibition of the norepinephrine release. So it decrease the BP. That means the release of norepinephrine is inhibited. So that's why the BP is decreased. So it's used for the treatment of hypertension. If the patient have the hypertension condition, we can use this one because the clonidine will be inhibit the release of norepinephrine and it decreases the BP. Okay, so it's used to minimize the symptoms that accompany withdrawal from opiates, tobacco, smoking, and benzodiazepines. One of the important use also. This is also very important. We can expect the questions based on this. Okay, the clonidine is used to minimize the withdrawal symptoms of opiates, tobacco smoking, and benzodiazepines. Okay, the main side effects for clonidine is lethargy. Lethargy means lack of energy, sedation, constipation, xerostomia, we know, dry mouth, and abrupt discontinuation. That means suddenly stopping a medicines. Some side effects are coming. For that purpose, it's also produced the rebound hypertension. Okay, so abrupt continuation, that means it's the discontinuation of clonidine, it's producing the rebound hypertension. That means sudden increase in BP. Very very important point. We can expect questions based on whatever I highlighted here. Okay. And the next we are discussing here, the albuterol and terbutaline. Albuterol, we know it's also known as the salbutamol. Okay, so the receptor specificity mainly beta-2. It's mainly used in the treatment of bronchospasm. That means the short-acting beta-2 agonist, it's producing the bronchodilators action. So that's why it's used in the treatment of bronchospasm. Okay, the albuterol mainly used in the management of acute asthma symptoms, and the terbutaline is mainly used for the off-label as uterine relaxant to suppress the premature labor. Okay, one of the important point, we can expect questions based on this also. Okay, the other side effects for this one, albuterol and terbutaline, is tremor, restlessness, anxiety, apprehension. Apprehension means anxiety or fear. out of this, the tremor is one of the important side effect of albuterol and terbutaline. Okay. The important point I highlighted here, oral administration of these drugs causes tachycardia or arrhythmia, because these drugs have the beta 1 receptor activation, especially in patients with cardiac disease. So that's why it's producing the tachycardia or arrhythmia. And also the MAVO inhibitors are contraindicated with these drugs. The reason is it increases the risk of adverse cardiovascular effect. Okay, so that's why these drugs are contraindicated with MAVO inhibitors. Okay. The next drug we are discussing here, the salmeterol and formoterol. Receptor specificity for salmeterol and formoterol, mainly beta 2 selective. That means we know beta 2 selective means it provides the bronchodilation action, and also it's known as LABAs, that means long acting beta agonists, salmeterol and formoterol. These agents are not recommended as monotherapy, but are highly efficacious when combined with corticosteroids. So these drugs are mainly high efficacious by combined with corticosteroids. Okay, the main important point is LABAs based on the beta 2 receptors action. Okay, main uses of these drugs is it's used for the treatment of bronchospasm. It's a long acting drug also. Okay, the main reason of treatment of bronchospasm, we know the beta 2 action it's producing bronchodilation, so that's why it's used for the treatment of bronchospasm. Okay, the next drug we are discussing here, mirabegron. Mirabegron, it's a beta 3 agonist specificity is showing. Mainly the beta 3 agonist, beta 3 receptors is presently in adipose tissue and bladder also. So it's used for the patients with overactive bladder, and it relaxes the detuses smooth muscles and increase the bladder capacity by decreasing the urination. This is the main action of mirabegron, and also it's contraindicated in patients with uncontrolled hypertension. That means it increases the BP, so that's why it's contraindicated. Okay. The next one is mirabegron have some drug interactions. First drug we are discussing here, mirabegron, if we are giving with the digoxin, mainly the digoxin is metabolized by CYP enzyme 2D6, CYP2D6. So the mirabegron, the digoxin is metabolized by CYP2D6. If it's combined with mirabegron, the mirabegron inhibit this enzyme and it increase the level of digoxin. So what's happening on their digoxin toxicity will producing because the digoxin is very narrow therapeutic index, so that's why it's producing this digoxin toxicity. We know any slight variation, the narrow therapeutic index means any slight variation in this level, it will become toxic. It's producing the toxicity. So that's why, same as like metoprolol also, if the metoprolol giving with the mirabegron, the metoprolol is metabolized by CYP2D6 enzyme. If it's used with the mirabegron inhibit this enzyme, so the metoprolol level is increased. Okay, it's very very important. The CYP2D6 enzyme mainly, what is that? It's an isoenzyme, that's I mentioned there. The digoxin and metoprolol both are metabolized by this enzyme. Just for understanding, I mentioned that point. Okay, but the drug interaction is very very important. Okay. And the next section we are discussing the indirect acting adrenergic agonist. It's mainly causes the inhibit the reuptake or inhibit the degradation of epinephrine or norepinephrine. So that's why it's called indirect acting adrenergic agonist. The first drug is amphetamine. Receptor specificity for this drug is alpha, beta and CNS. So what is amphetamine doing? Amphetamine increases the release of catecholamines such as dopamine and norepinephrine from nerve terminals. And also the main uses of amphetamine is it's used as a CNS stimulant in the treatment of children with ADHD. And also it's used for the narcolepsy and appetite control. The amphetamine also used as an appetite control. Okay, ADHD means everybody know attention deficit syndrome. So the amphetamine main uses are these are the main uses. Okay, the next drug we are discussing the tyramine. Tyramine, it's a byproduct of tyrosine metabolism. We already discussed this one. And the tyramine is not clinically useful drug, but it is mainly found in the fermented foods such as aged cheese and wine. One of the important point based for the tyramine is cheese reaction. What is cheese reaction? I already detailedly described here, but we can expect questions based on this. Okay, so we already mentioned it's mainly found in the fermented foods such as aged cheese and wine. So the tyramine is mainly oxidized by MAVO in the gastrointestinal tract. But if the patient is taking the MAVO inhibitors drug and with the tyramine, what is happening on there? It can precipitate the serious vasopressor episodes. What's mainly happening on them? The tyramine can enter the nerve terminal. That means the tyramine is not metabolized, so that's why it's enter the nerve terminal and displace the stored norepinephrine. The released catecholamine, it's producing, it's mainly acting on the adrenoreceptors and producing the action. This reaction is mainly called cheese reaction. Okay, again I explained here for understanding. The cheese reaction mainly it's termed used to describe the hypertensive crisis. Dangerously high blood pressure is called. This condition is called this one. And how it's producing, that can occur when someone consumes high tyramine foods like certain aged cheeses while taking monoamino oxidase inhibitors, MAVO inhibitors. That time this reaction is producing. Okay, and the tyramine, it's an amino acid that can cause the blood pressure to spike, increase the blood pressure. Tyramine can increase the blood pressure if it's not broken down properly by the body. I think everybody understood this point because the tyramine is mainly metabolized by MAVO. If the patient is taking MAVO inhibitors with tyramine, the tyramine is not metabolized, the level of tyramine will be increased, then it spike the blood pressure. That is mainly happening on there. Okay, very important point. We can expect questions based on this. Okay, the next drug we are discussing here is cocaine. Cocaine will block the sodium chloride dependent norepinephrine transporter. So it's required for the what is this one, sodium chloride, that transporter is required for cellular uptake of norepinephrine into the adrenergic neuron. So the cocaine is block this transporting system. And what's happening on there, it's accumulate in the synaptic space and it increase the concentration of these neurotransmitters in the synaptic cleft. Then it increase the sympathetic activity and potentiation of the actions of epinephrine and norepinephrine. These are the mainly doing the cocaine. Okay, the cocaine is indeed used as a local anesthetic also, particularly in medical procedures involving the nasal passages. It's mainly used the cocaine as a local anesthetics. And it's numbing, why its reason is its numbing and vasoconstrictive properties is make it effective for surgeries and diagnostic procedures in the nose, mouth or throat. And these are the main uses of cocaine. Okay, it's used as a local anesthetic. And the last one is mixed acting adrenergic agonists. We already mentioned in the classification slide, two drugs are mainly discussing here, ephedrine and pseudoephedrine. So the ephedrine compared with ephedrine, the pseudoephedrine have less CNS effects only, and the receptor specificity mainly alpha, beta and CNS. Main uses of the mixed acting adrenergic agonist, ephedrine and pseudoephedrine, are as it's used as a nasal decongestant, so it's raise the blood pressure also. And ephedrine and pseudoephedrine are not catechols and are poor substrates for COMT and MAVO. Then it's therefore these drugs have a longer duration of action. Okay. Because it's not it's poor substrates of COMT, it's not metabolized by this one. Okay. Then these have the excellent absorption orally and it's penetrate into the CNS. The ephedrine we already mentioned in the first point. Ephedrine have more CNS effect compared with pseudoephedrine. So the ephedrine will cross the blood-brain barrier and it causes the CNS side effects when administered systemically. Okay, one of the important point. And ephedrine produces a mild stimulation of the CNS and it improves the athletic performance also by increasing the alertness and decreasing the fatigue. Okay, ephedrine raises the systolic and diastolic blood pressure by vasoconstriction and it's also producing the cardiac stimulation. So that's why it's used for treating the hypotension. We know the action is mainly alpha beta, alpha the vasoconstriction effects, so that's why it's used for this purpose, and it's also used for the we can use to treat the hypotension. Okay, and pseudoephedrine is primarily used orally to treat nasal and sinus congestion. We already discussed it have less CNS effects, so the pseudoephedrine is primarily used for orally to treat the nasal and sinus congestion. Okay, the next slide we are discussing what are the actions in the heart, beta 1, actions in heart, vascular smooth muscles. Same the table as per the copy from the Lipin court. You can check it if you want. You can check the link in the description box. You can check it on there also if the slide is not clear. Okay, and the next slide I mentioned whatever the drugs action, the summary of the table I mentioned here. It's also same as like Lipin court table. Okay, whatever the each drug and whatever the receptor specificity and therapeutic uses of the drugs is just mentioned in a table. It's also very helpful. You can just at last you can check it this one also. Okay, from the next slide I am discussing the study questions. I already mentioned when I start the video. I mentioned each chapters from the ANS and till the adrenergic agonist. I mentioned the discussion question from the Lipin court also. You can check it that one also. It's very helpful. Try to answer the questions. Okay, today I'm just wind up here. Thanks for your support and please subscribe, share and like my videos also. Okay, today I'm just wind up. Thank you.